rise, please.
Thank you for standing, folks. Please be seated.
Your next witness, please.
Thank you. Your Honor, the defense calls Dr. Edward French.
All right.
Do you solemnly swear or affirm, under penalty of perjury, the testimony you're about to give will be the truth, the whole truth, and nothing but the truth, so help you God, or do you so affirm?
I so affirm.
Through the labor form, I'm just for the
All right.
speaking.
Okay.
Can you hear me? Okay. Go ahead, Mr.
Thank you, Judge.
Thank you.
Dr. French, could you please introduce yourself to the jury?
Yes, my name is Edward French.
What do you do for a living?
I'm a professor of pharmacology at the University of Arizona College of Medicine
How long have you been so employed?
since 1988.
Can you please describe for the jury your educational and professional training?
Sure. I'll start with, I got my doctorate degree in pharmacology at UCLA in 1976, and then from there I did 3 years what we call postdoctoral research at the Salk Institute in San Diego, and then an additional year of research at the Max Planck Institute for Psychiatry in Munich, Germany, before taking on a academic position at the University of Maryland at Baltimore College of Medicine at the Maryland Psychiatric Research Center, where I was there until 1988.
What is pharmacology?
Pharmacology is basically the study of drugs or substances that affect our bodies.
Through the course of your studies and your instruction at school, are you familiar with the effects of ethanol, Xanax, and THC on the human body?
Yes, I am.
Were you engaged by the defense to assist in this case?
Yes, I was.
And just to be clear, you're being paid and have been paid for the time that you've spent on this case, correct?
Yes, I am.
Is that customary for expert witnesses in your field?
Yes.
Have you been paid to express or form a particular opinion?
No, I have not.
What is a benzodiazepine?
A benzodiazepine is it's actually a very big class of medications that are used for the relief of anxiety or muscle relaxation, in some cases for seizure control. There are many chemical substances within this class of drugs. The most common one, which I think most people are aware of, is Valium or diazepam. That would probably be the easiest example of a benzodiazepine.
Is Xanax also a benzodiazepine?
Yes, it is.
Are there certain benzodiazepines that have a more rapid onset of action than others?
Yes, there are.
Are there certain benzodiazepines that are more potent than others?
Yes.
If we were to talk specifically about Xanax, and by the way, is Xanax also referred to as alprazolam?
Yes, it is.
Xanax is a little easier for me to pronounce. So I'm gonna
Okay.
call it Xanax. Where does Xanax fall in that spectrum of benzodiazepines with respect to onset of action and potency?
It has a rapid onset of action and is considered to be one of the more potent of the benzodiazepines.
You indicated that, if I understood you correctly, benzodiazepines are sometimes used for the treatment of anxiety.
Yes.
And are benzodiazepines sedatives?
Yes, they are.
What is a paradoxical effect?
A paradoxical effect is exactly what it sounds like. It's a paradox. It's something that you don't expect to happen. And if you were talking about the benzodiazepines, should I go with that? Okay.
Please, doctor.
If we're talking about the benzodiazepines, people are prescribed benzodiazepines to reduce anxiety, to help them get to sleep, and maybe for a few other things. But sometimes it happens that the taking of a benzodiazepine will produce just the opposite effect. So a person will become, rather than sedated, they become excited. Rather than calm, they become irritable. And there have been many cases of documented individuals who become rageful and very hostile under the influence of a benzodiazepine. So that's a paradoxical reaction. The paradoxical really means that it occurs just out of nowhere. We don't really understand why it occurs, it just does. So individuals can be taking a benzodiazepine maybe for weeks, nothing happens, and all of a sudden, right out of the blue, they end up with a paradoxical reaction.
Have there been studies with which you are familiar that explore the frequency of paradoxical effects of benzodiazepines?
There have been attempts to try to really nail it down, and it's really kind of difficult. So there's a big range of numbers. One study will say maybe 1% of people who are on benzos will have a paradoxical reaction. Other studies say it could be as high as 13%. And I think the problem there is because of the individuals. So the underlying personality always plays a very, very big role in how drugs affect people.
Could you flush it out a little bit? What type of underlying personality issues may either increase or decrease the likelihood that a particular individual will have a paradoxical effect to a benzodiazepine?
People who are easy.
Objection, Your Honor. Maybe we approach?
Sure. Can you repeat the question, Doctor?
Yes, please.
What type of underlying personality issues could either increase or decrease the likelihood that a particular individual may have a paradoxical reaction to a benzodiazepine?
Well, the clinical literature suggests that individuals who have maybe impulse control issues, in other words, people who can maybe fly off the handle easily, may be more sensitive to benzodiazepines. Individuals who have anti-social personality disorder may be another class of people who may be negatively affected by the benzodiazepines.
What is a disinhibitory effect?
Disinhibition?
Yes.
Yes, okay. I'll start by explaining a little bit about the brain, I guess.
Please.
So there is that part of our brain which keeps us under control, keeps most humans under control. It's right up here above our eyes. It's the prefrontal cortex. And it's exerting inhibitions on what we do. It keeps us on track, so to speak. And what disinhibition is there are substances, there are chemicals, there are drugs which will actually inhibit those parts of the brain so that we become more excitable. We take away the control mechanism. So we overreact in certain situations when we normally wouldn't overreact.
If hypothetically an individual were to experience a paradoxical reaction, let's say to Xanax, would disinhibition be one of the ways in which that could manifest?
That is probably the way, because the benzodiazepines, like Xanax, they act to inhibit that part of our brain, which keeps things under control. And there are other drugs which also do the same thing. So the addition of two drugs which act in that same way is kind of sets you up for problems.
Is there a correlation between disinhibition and agitation, toxic psychosis, hostility, and rage?
That's all part of the disinhibition. So we remove all those mechanisms that we have that are controlling our behavior and enabling us to process our environment and to figure out how we're going to solve this problem. And if you have these medications on board which prevent that from happening, then you can't process very well. So you cannot pay attention to things that are going on as well as you should. Your processing speed may be affected, so you may overreact. And so there are many things which happen when you have these substances that disinhibit.
Assuming hypothetically that a person were to experience disinhibition as a result of benzodiazepine consumption, would you expect that to be dose-related?
Yes and no. There are some studies which say that it is dose-related, and there are other studies that say because it's a paradoxical reaction and it can happen just out of nowhere, then it may be hard to say that a particular dose is going to cause a particular type of disinhibition.
Given the fact that Xanax is a benzodiazepine with a particularly rapid onset of action, is there any correlation between its likelihood to trigger a paradoxical reaction versus another benzodiazepine?
I don't think so, not on that basis.
Okay. Are you familiar with the term or the concept of a therapeutic dose or a therapeutic range?
Sure.
What is that?
Well, the easiest way to explain that is when drugs are being developed, which is what pharmacologists do, they are trying to develop a drug for a particular condition. And I think the easiest way to explain this is, let's say we are trying to develop a drug to reduce blood pressure by 25 millimeters of mercury, get 25 points down. So drug companies will go through a series of studies to figure out how much of a particular medication, that one they're making, will reduce the blood pressure by 25%. That's their therapeutic target. And so they come up with a dose, and they give that dose to you. They say, please take this once a day to lower your blood pressure. So that is where you get the therapeutic dose.
Does a particular individual need to be at the bottom or the minimum therapeutic dose before the particular drug or medication involved is having an effect on them?
No, and it gets back to the point that these are all dose-related. So if you take that particular drug and you don't reduce your blood pressure by 25 points, but you could reduce it by 10. So you still get an effect, but it's not the therapeutic target.
Is it possible for a hypothetical concentration of Xanax in a person's system at 4.3 nanograms per milliliter to affect that person?
Sure.
Are you familiar with any studies that have determined a lower threshold at which Xanax can affect someone?
I'm not familiar with the studies that have looked at all the various doses of Xanax. I'm not. So I can't really answer that.
Okay. Irrespective of being put on the spot and being asked to recall these specific studies, with regard to that particular concentration of 4.3 nanograms per milliliter, do you have an opinion as to whether that is capable of affecting a person?
Well, I think I'll try to answer that. I think I know where you're asking, but I'll try to answer it my way,
Sure.
Which is there are compilations of drugs where they lay out how much of a blood level would be therapeutic. So there are those data sources. So 4.1 or whatever it might be may not be in the therapeutic range. It could be below the therapeutic range. But the way I'll answer that is it does not necessarily mean that you would not get an effect from having a blood level of 4 of Xanax. You still could have a blood level, but maybe it's not producing the kind of therapeutic effect that it was designed to produce.
Okay. And at great risk of shifting gears, somewhat abruptly, talking about THC. Is that the active metabolite in cannabis?
THC is a psychoactive not a metabolite, a psychoactive active substance.
Okay, thank you. Are you familiar with any studies that would determine whether a concentration of 7.6 nanograms per milliliter would be capable of impairing the particular individual involved?
There have been many studies trying to pinpoint a blood level of THC which will affect a variety of behaviors. And the reason for that is more important now than ever because of the use of medical marijuana and states that are actually going to allow recreational marijuana. So there are studies now which are trying to find out what blood level of THC will cause a form of impairment, so to speak, in terms of driving or whatever it might be. There have been studies in the past which suggest that levels as low as 1.6 to 2 nanograms per milliliter in the blood can cause some form of impairment. Colorado actually established a level of 5 nanograms per milliliter as a level which, if you have that level in your blood, Colorado says you're impaired, at least in terms of the driving. So 7 would be kind of on the high side of what the studies have shown.
Okay. Are the effects of THC on the cognition and emotional reactions to individuals something that's been studied?
Yes.
Okay. How does THC affect one's ability to perceive events and to respond to them?
Well, it alters perceptions. Try not to be flippant about this, but for those who have had experience with THC, there can be distortions of sense of time, sense of time in a sense, sense of space. So perceptions can be distorted, for sure.
What about fashioning responses to external stimuli?
Well, THC slows our ability to process the things that are going on in our environment. It just basically slows it down. So the easiest way to think of all these substances and how they affect our behavior is, are they depressants? And the answer is yes. THC is a depressant, Xanax is a depressant, and there are other depressants that people take. So they all slow the process, our processing down. And they all take away our ability to focus our attention on particular things. So we may focus on one particular thing, but there may be other things that are very, very important going on around us that we don't pay attention to. And so THC does that.
We talked a little bit before, Doctor, about how one's underlying personality may contribute to the likelihood of a paradoxical reaction to benzodiazepines. Are there other things that can contribute to that, such as concurrent ethanol usage or alcohol consumption?
To the paradoxical reaction?
Yes, Doctor.
There's quite a bit of literature out there which suggests that you don't combine alcohol with a benzodiazepine because you get two substances which are profoundly disinhibitory. They both act on the same neurotransmitter system in the brain, which is controlling our ability to comport our behavior, and they both inhibit it. So when you add one on top of the other, you get a bigger bang for your buck.
In other words, they're greater than the sum of their parts?
Some people will say that they're additive, and then there are other people who say they're synergistic. In other words, they are 1 + 1 is 3 would be synergistic. Additive would be 1 + 1 is 2.
Is the effect to which ethanol or alcohol consumption may increase the severity of a disinhibitory reaction to benzodiazepines dose-related with respect to the alcohol level?
Yes.
So in other words, the more alcohol someone has in their system, the more likely it is, or the more profound the increase to the disinhibition would be.
That's exactly right, sure.
Are you familiar with studies that have been done related to humans' reaction to alcohol consumption at varying concentrations?
There's been a lot of studies about that, again, relating to trying to figure out what blood alcohol level we should say is causing a person to have a particular form of impairment.
Do all people react to alcohol the same way?
No.
If you have two people and they weigh the exact same and they're dosed with the same exact amount of alcohol, would they necessarily have the same reaction to it?
No.
What type of factors could potentially affect the extent to which someone will be affected by alcohol consumption?
Well, we know for sure that men and women are different. Women are much more sensitive to alcohol than men. That is a given. It's been studied over and over again. Again, if you have an individual who maybe has a little bit of a, let's say, a testy type of personality or an impulsive type of person, that person may respond to a dose of alcohol which another person might not respond to. So there are the same kind of things that go along with the benzodiazepines.
What about tolerance?
Tolerance develops to alcohol, yes.
What is tolerance?
Tolerance is a condition where you need to take more of a substance to produce the same effect that you got the first time around. That's the easiest way to explain it.
Is alcohol, ethanol, a central nervous system depressant?
Very much so.
Does that mean that everybody who drinks alcohol will be sedated and passive?
No, because you go through stages, depending upon the amount of alcohol you're taking.
I realize that it may be difficult to ask, all the more so answer this question in the abstract, and if so, please let me know. I'll rephrase it, but would you consider a blood alcohol concentration of 0.208% to be a high level?
0.208?
Yes.
I would answer the question yes, but I would also say it depends on the individual's history of their use of alcohol.
If somebody has a blood alcohol concentration of 0.208, does that necessarily mean that that person is stuporous and sedated?
No, not at all.
Let's take it even higher. Let's assume we're talking about somebody with a blood alcohol concentration of 0.285%. If somebody has that amount of alcohol in their system, does that necessarily mean we would expect them to be in a stupor or sedated?
No, not at all.
Which benzodiazepines are most frequently associated with paradoxical reactions?
Well, as far as I can recall, every benzodiazepine that is out there has been linked to a paradoxical reaction. I think that the high-potency ones with the fast onset, like triazolam and alprazolam or Xanax, I think have been found to be probably more problematic.
Are you familiar with any studies that have explored the correlation between acute or chronic marijuana usage and premature responding in conflict situations?
There have been studies that have looked at that, and again, it gets to this issue of what marijuana does to our processing ability. Our processing kind of slows down. We lack the ability to attend to particular things as well as we should, and so we may process in an abnormal type of way and react in an abnormal type of way to that situation.
What about the effect that THC has on one's ability to inhibit an inappropriate response to external stimuli?
THC reduces our ability to inhibit a response, so we get more inappropriate responding.
And what about the role THC plays in one's ability to process external stimuli in a conflict situation?
Well, that's what I was getting at, because under the influence of THC, we don't attend very well to everything that's going on around us. And so in a very difficult situation, let's say, an interpersonal kind of conflict situation, we may not be attending to everything that's happening in that situation, and we may just respond to something that's right there in front of us, and that may be an inappropriate response.
Shifting gears back to benzodiazepines, is it the case that if someone is taking Xanax, that it's a binary situation? In other words, are they either going to be disinhibited or sedated?
No, it's not.
It could have no effect at all.
Well, yeah, actually, there are people who don't have much of an effect from benzos, yes.
Or it could affect them but not manifest in either of those ways?
Yes, exactly.
Are you familiar with the process by which the body metabolizes THC?
Yes.
How is THC metabolized by the body?
Well, it's metabolized very, very quickly, actually, by the liver, by liver enzymes. THC is a very interesting substance because its effects usually don't last very long, and it is removed from the blood very quickly because it likes to enter tissues that have a lot of fat content to them. So it leaves the blood very quickly. Onset of action occurs within minutes after people smoke it. Peak effects may occur within 30 minutes, and the effects may be over within 2 hours. Blood levels are almost negligible at 3 hours. But it's metabolized. It is broken down by liver enzymes.
Assuming hypothetically you have a situation where a urine sample is collected from a subject at 9 o'clock in the morning, and a blood sample is also taken at that time.
Okay.
The blood and the urine collected at 9 a.m. is tested for the presence of cannabinoids, and both of those tests are negative.
Okay.
What conclusions, if any, can you draw as to the presence or absence of THC in that person's system at 1 o'clock in the morning, 8 hours before the samples were collected?
So let me make sure I understand. So there's no cannabinoid in the blood or the urine at 9 o'clock in the morning.
Correct.
And you wanted to know how much would be there at like 9 hours before?
8 hours earlier.
8 hours earlier? You can't know that. It's not. You can't possibly determine that.
Okay, but can you establish that there was none? The person was not using marijuana at 1 o'clock in the morning if
No.
they test negative at 9 a.m. with their urine?
No, you can't. You can't say that there wasn't anything there or that there was something there because you don't have any evidence. There's no evidence.
Oh, let me ask it this way. How long after a person uses marijuana would you expect to see evidence of cannabinoids in their urine?
Oh, in the urine?
Yes.
Oh, yeah, okay. I'm sorry, I misunderstood. So yes, in the urine, there would be the metabolite, the carboxy metabolite of THC would be found in the urine, probably 12, maybe even 24 hours after smoking.
And certainly sooner than 8 hours. In other words, 8 hours would provide more than enough time for the body to metabolize the THC to the point where there'd be evidence of that in the person's urine.
Sure.
Thank you, Doctor. No further questions, Judge.
Mr. Shea?
Good morning.
Doctor, is there a difference between THC and THC-COOH?
There is a very big difference.
What is the difference?
THC is a psychoactive ingredient in marijuana, and THC-COOH is the inactive metabolite.
Okay. So that's not having, the inactive metabolite means it's not having any effect on a person's thought process or
Right.
any disinhibitory effects. Is that fair?
That's right.
So if one were to find a level of THC in a person's blood of 1.9 nanograms per milliliter, would you agree that that's a very small level, very low level of THC?
It is a low level, yes.
Okay. I'm going to jump around a little bit, Doctor. I'm sorry. Doctor, would you agree that most paradoxical rage reactions that have occurred between have been reported either in previously violent patients or in psychotic patients, particularly those suffering from schizophrenia? in whom benzodiazepines are reported to produce an increase in paranoid ideation and aggressive tendencies?
So let me clarify. Are you asking if the paradoxical reaction is mostly in people who have psychotics disorders?
Yes.
No, that's not true.
Well, a lot of the studies that have been conducted with regards to the paradoxical reaction have been with in those types of populations. Is that correct?
There have been studies in those types, yes.
So when you say that the occurrence of a paradoxical reaction could be between 1% of the time or 13% of the time, the higher end of that is in specific populations with those types of histories. Isn't that correct?
I believe that the higher one would be in individuals who have, I think it's personality disorder problems, yes.
Doctor, would you agree that if a substance is only in a person's urine, that substance is not having an effect on them at that time?
I would say yes, it's not.
Okay. And I think counsel asked you, there's considerable variations in the effects of alcohol from one person to another, is that right?
Yes.
And indeed, the majority of people do not become aggressive when they consume alcohol, is that correct?
Oh, that's very true.
And further, aggressive behavior doesn't always involve alcohol, is that right?
That's true. That's true.
And in fact, aggressive behavior actually decreases alcohol actually can decrease aggressive behavior in people, is that correct?
It can, as the dose escalates, yes.
In most of the experimental studies on people showing aggression were done at lower BACs, like 0.06 and to 0.14, somewhere in there. Is that right?
Can you repeat that again, please?
Most experimental studies done with people as the subjects are done at BACs between 0.06 and 0.14. Is that correct?
Yes, they're done at the lower end for ethical reasons.
But there is anecdotal evidence that would suggest that people exhibit sedation at higher BACs over 0.20. Is that correct?
Sure.
What types of, what would people, typically, what are people experiencing when they're at a BAC between 0.21 and 0.29?
I'll answer that by saying that that would be an individual who has no history of alcohol use. So that would be someone who hasn't been drinking, and you would get them up to a level of 0.2, as you said, or whatever it might be, and they would probably have already gone through the disinhibitory phase. They would probably have already gone through the talkativeness phase, and they would still have impaired judgment. They would probably be stuporous in a sense. They would probably have slurred speech. They'd have difficulty maybe doing a field sobriety test. So it would be at that level in those individuals who have not been drinking.
Sluggishness?
Mm-hmm. Yes.
Severe motor impairment?
Yes.
Difficulties with perception?
Yes.
Balance?
Yes.
Gait?
Yes.
Indeed, one might expect to see impaired gross motor control even between 0.11 and 0.2.
In a naive person, yes.
Even staggering.
Yes, in a naive person.
Increased reaction time?
Yes.
Would you agree that the quantity of alprazolam or Xanax of 4.3 nanograms per milliliter is a relatively low level?
It is a relatively low level, yes.
Below therapeutic level, right?
Yes.
And the studies that investigate the studies that have observed the paradoxical reaction are within the therapeutic level, isn't that correct?
Most often, yes.
In fact, there's not a lot of studies discussing those low levels of Xanax. Is that fair?
That's correct, yes.
Paradoxical reactions are rare.
They are relatively rare, thank goodness.
In most instances, benzodiazepines diminish anxiety, fear, and irritability. Isn't that correct?
Yes, that's why they're prescribed.
Isn't it true, sir, that THC has been shown to reduce the likelihood of aggression when combined with alcohol?
There have been studies which have found that. That's true.
Fair to say that experimental studies in animals and in humans demonstrate that the effects of acutely given alcohol engender a biphasic dose effect curve on a range of aggressive and competitive behaviors?
So biphasic, you mean, do you have a definition of what you mean by biphasic?
Well, maybe I can flesh it out a little bit. Would you agree that in low acute doses of alcohol, it's been observed that there is an increase of threat and attack behavior, but at high acute doses of alcohol in a variety of studied populations, including college students, there's a decrease in aggressive or attack behavior.
There have been studies like that, yes.
And .285 would be on that high level. Is that fair?
It would be for a person who does not have a history of drinking alcohol.
If I may have a moment, Judge.
Sure.
Nothing further at this time, Judge.
Mr. Davidson?
The prosecutor was asking you questions about the stuporous and sedative effects of alcohol at higher concentrations, correct?
Yes.
In response to his questions, you referred to a naive person.
Yes.
What's a naive person in that context?
A naive person is a test subject who is not an alcoholic when you think about it. So when they were trying to figure out the blood alcohol levels which would produce certain behavioral changes, they didn't do those studies in people who had a history of drinking. They did them in normal, non-drinking people so they could set a standard, because once you enter into that realm of what people's history is, things change drastically. So a person can be an alcoholic. And I'll give an example of this because I work with a colleague who is a physician. An alcoholic can have a blood alcohol level of 0.3 and in some cases 0.4 and walk into an emergency room and be totally coherent about the problems that they're having. A 0.3 or a 0.4 in a naive person would probably put them into a coma. So it's the history which is very important. So when you're doing a study to try to find out what are the behavioral changes that occur with various amounts, you do it in what we call naive people. So you get a baseline.
It sounds like you're also describing some of the same concepts involved in tolerance.
That's exactly right, yes.
Does someone have to be a full-blown alcoholic, for lack of a better term, before their tolerance is going to affect the way higher concentrations of alcohol will affect them?
No, not at all.
So these studies that were done that show people being stuporous and having problems with balance and whatnot, and the other characteristics that Mr. Shea referred to were done with people who basically usually don't drink at all.
That's correct. That was what the National Highway Traffic Safety Administration was trying to establish for a policy to determine what we would call impairment for people who are, let's say, pulled over for erratic driving and alcohol is on board.
So hypothetically, if you were dealing with somebody who has a weekly or a biweekly hang or a social event they participate in where alcohol is consumed, you would expect them to have a higher tolerance than a naive person.
Right. They have a higher metabolic tolerance too. Their liver is able to break it down faster.
Is it possible you could have an event where a subject acts aggressively or violently, and they have 4.3 nanograms per milliliter of Xanax on board, and that Xanax plays no role whatsoever on their conduct at that time?
That's possible, sure.
I mean, a person could just be an aggressive person all the time, right?
That's exactly right.
If a person is coherent and communicative and is not demonstrating any deficits with their cognition at a blood alcohol of 0.208, does that suggest that person has tolerance for alcohol?
I would make that conclusion, yes.
Thank you, Doctor.
All right, let's turn to members of our jury and see if they have any questions for this witness. Looks like we do, so I'll see counsel and court reporter at sidebar. All right, Doctor, the jury does have some questions for you. The first question is, if someone had been drinking alcohol for several hours and was at a 0.285% BAC at the time of testing, does the time frame in which they had been drinking affect the way the alcohol affects them or the reactions they have to the alcohol?
That's a little bit of a hard question. So the way I would interpret that is, if you start drinking alcohol, your body starts eliminating alcohol. And so, as you know, if you want to be careful at a party, you'll drink your 1 beer per hour, and you will probably walk away with the blood alcohol that will not label you as impaired. As you keep increasing the amount of alcohol taken over a shorter period of time, your blood alcohol level is going up. Your body is still eliminating it, but it can't eliminate it fast enough. So I'm not sure I'm getting to the answer that you were looking for, but you will gradually still increase your level of alcohol, but you start to become tolerant to some of the effects of alcohol as the blood level of alcohol increases. So some of the behavioral effects are lessened, but your blood alcohol level is still rising. I hope I answered the question.
The next question is, does drinking alcohol over a long period of time affect the typical stages a person goes through while drinking versus if you drank the same amount of alcohol in a short period of time?
Oh, that gets to the issue of what we call binge drinking. And binge drinking is taking in a very large amount in a short period of time. So in other words, instead of going to a party and drinking a beer every hour for 4 hours, you drink 4 in 1 hour. That is going to cause a bigger effect, for sure. Your blood alcohol level will be much higher.
The next question is, what alcohol history would be needed for a person to still be considered as naive? 1 beer a day, 1 beer a week?
I think generally the medical community basically says now that it's okay medically for males to have 2 alcoholic drinks per day, and for females 1 alcoholic drink per day. So the medical community really is kind of defining what they would consider to be kind of a naive, maybe problematic drinker.
Follow up, Mr. Davidson.
If somebody is binge drinking or consuming alcohol, let's use the hypothetical 4 drinks that you used over a short period of time, is that more likely to result in a higher peak BAC than a person who consumes those 4 drinks over a longer period of time?
Oh, absolutely, yes.
Is that due to the elimination rate?
Yes.
Okay. What is elimination rate?
The elimination rate is the time that it takes for the body to start eliminating a particular substance. So with alcohol, the elimination rate is approximately, on average, about 0.015 milligram percent per hour. That's on average. It may go up to as high as maybe 0.2 milligram percent per hour. So, but on average, you eliminate 0.015 milligram percent per hour of alcohol.
Is it pretty well understood that there's a range out there with regard, a range in the population with regard to person's elimination rate?
Yes, that's where the numbers come in. Where the average would be 0.015, so there might be a 0.012 versus a 0.2 in terms of elimination, because everybody's different.
Are there any social or other factors that could affect a person's elimination rate?
Social factors?
Let me back it up and ask more broadly. What factors might affect a person's elimination rate?
Their history of alcohol use could, because the more you drink, the more your liver deals with the alcohol that you drink. So the liver starts to gear up and start to figure out a way of getting rid of that alcohol. So a history of alcohol use could probably increase the rate of elimination.
And then if you take it further and a person reaches the point through either alcoholism or some other contributory illness, they have impaired liver function, do you expect the elimination rate to be affected by that?
Yes, if you have impaired liver function, then your body cannot eliminate the alcohol as efficiently as it normally could.
So these factors could either increase or decrease one's elimination rate.
Right.
Thank you, Doctor.
Mr. Shea.
Thank you, Judge. Just one question, Doctor. I think that you indicated, and correct me if I'm wrong, that as the consumption of alcohol is extended over time, that some of the effects of alcohol are diminished. In response to the first one of the jury's questions, I think you said that if you drink a fair amount over a longer period of time, your BAC is getting up there, that both the elimination rate can be slowed down, right?
No, the elimination rate is not slowed down.
It doesn't change?
No.
Okay, so, and then I guess my question was, did you say, and again, correct me if I'm wrong, that as you get into the higher BACs, some of the effects of the alcohol consumption are diminished?
Yes, I would say that, because what happens is the body starts, or the brain actually, starts to experience some development of tolerance to some of the effects of the alcohol. So you're not going to pass all of a sudden right from being perfectly fine to being comatose. So you're going to be escalating your blood level, your brain level, but your brain is starting to adapt a little bit. So you could have a high blood alcohol level, which in a naive person maybe would make them stuporous or maybe make them sluggish, but in another person, that may not be the case. They may be tolerating that.
And with those, and by that diminishment of the effect, would you include disinhibition, inhibition in that?
Disinhibition will always occur. That's basic.
Okay, so there's no reduction with tolerance of the disinhibition.
It occurs. The disinhibition will always occur, but with tolerance, it occurs at a higher blood alcohol level.
Okay, thank you.
Redirect.
No questions, Judge.
Can this witness be excused?
Yes, Your Honor.
Doctor, thank you for your testimony. You are excused.
Thank you.
All right, folks, let's go and break a little bit early for lunch. Please remember the admonition. We'll be back together at 1:30.